Thanks very much, Professor, for that very fantastic talk. And lastly, for this session, we have our third speaker, Professor Yoshi, who has pre-recorded this session on hereditary ATTR with nerve involvement.
Hello everyone, I am Yoshiki Sekilima from Shinshu University, Matsumoto, Japan. My topic today is how I care for my amyloidosis patients with nerve disease. Here is my disclosures. I'm from Shinshu University, Matsumoto, Japan. Matsumoto is located at the center part of Japan between Tokyo and Kyoto. Matsumoto is famous for Matsumoto Castle, which is a national treasure, beautiful mountain resorts, snow resorts, and wasabi farm. So Matsumoto is also famous for music. We have a big music festival every summer. So please visit Matsumoto if you have a chance. So next, I'd like to talk what amyloid is. Amyloid is a kind of trash of protein. Protein must fold into a particular shape like Japanese origami. And this shape determines its specific function. However, proteins may misfold under some circumstances, such as mutations in coding genes, and misfolded proteins may have aggregation propensity and form amyloid. Just as trash is separated by type, amyloids are classified according to their precursor proteins. For example, amyloid produced from TTR transthyretin is ATTR amyloid. Similarly, amyloid produced from immunoglobulin light chain is AL amyloid. Just as we produce trash every day at home, our bodies are constantly producing protein waste, but our body have ability to remove it. So what causes amyloid accumulation? One reason is increased amount of trash. In AL amyloidosis, abnormal plasma cells in the bone marrow produce large amounts of aggregate-prone immunoglobulin light chains, which are the source of amyloid. Similarly, in hereditary ATTR amyloidosis, TTR gene mutations result in the production of aggregate-prone TTR protein. The other cause is reduced ability to clean. In wild-type ATTR amyloidosis, aging leads to a decrease in amyloid clearance. This slide shows summary of major amyloidosis. Hereditary ATTR amyloidosis is induced by TTR gene mutation, and the precursor protein is variant TTR. On the other hand, aging is the main cause of wild-type ATTR amyloidosis, and precursor protein is wild-type TTR. The cause of AL amyloidosis is bone marrow abnormality, and the precursor protein is immunoglobulin light chain. In any type, neurological symptoms such as numbness in the hands and feet and autonomic dysfunctions are very common. So next, I'd like to talk about amyloid neuropathy. The important causes of numbness in the hands and feet associated with amyloidosis are carpal tunnel syndrome and polyneuropathy. Carpal tunnel syndrome is a disease in which median nerve is compressed at the wrist, causing numbness and movement disorders in hand. Lifetime probability of developing carpal tunnel syndrome is more than 10%. The condition begins with pain and numbness in the index and middle fingers, and the pain is intense in the early morning and can wake you up. As condition progresses, the area shown on the left becomes painful and numb, and the fingers lose strength. This slide shows hands of patients with carpal tunnel syndrome. You can see finger muscle atrophy like this, and carpal tunnel syndrome patients cannot make a circle with thumb and index finger, and patients have difficulty picking up things with their fingers. In polyneuropathy, damage spreads from long nerves to short nerves. Sensory impairment begins in the toes and gradually progresses upwards. When sensory impairment progresses to the knee, sensory impairment in the hands also appears, so-called glove and stocking type. Autonomic neuropathy is also very common in systemic amyloidosis. Representative autonomic nerve dysfunctions include orthostatic hypotension, diarrhea, constipation, nausea, vomiting, dysuria, impotence, and dyshydrosis. Next, I'd like to talk about therapy for amyloidosis. The principle of amyloidosis treatment is to reduce the amount of amyloidogenic proteins. For example, the first-line therapy for AL amyloidosis is daratumumab-based chemotherapy targeting abnormal plasma cells in the bone marrow and reducing the amount of amyloidogenic immunoglobulin light chains. So next, let's think about ATTR amyloidosis. This slide shows process of ATTR amyloid fibril formation. Precursor protein of ATTR amyloid is TTR. TTR is produced by the liver and secretes into the blood as a tetramer. ATTR amyloid fibril formation requires tetramer dissociation and monomer unfolding. Based on this model, TTR gene silencers such as patisiran, vutrisiran, inotersen, and eplontersen, and TTR tetramer stabilizers such as tafamidis, acoramidis, and diflunisal have been developed, and their efficacy have been confirmed. TTR tetramer stabilizers bind to the TTR tetramer and inhibit its dissociation, inhibiting the production of amyloidogenic monomers and preventing the production of new amyloid. This slide shows result of clinical trial of tafamidis. As you can see, tafamidis inhibited polyneuropathy progression by 51% as compared with placebo. TTR gene silencers block the production of TTR protein in the liver, preventing the production of new amyloid. This slide shows result of clinical trial of patisiran. As you can see, patisiran significantly inhibited polyneuropathy progression as compared with placebo. Next, I'd like to introduce our treatment experience with TTR gene silencers. At our university, 42 ATTR-B hereditary ATTR amyloidosis patients were treated with patisiran. 32 patients were male and 10 patients were female, and the mean age was 55 years. 10 patients were treatment naive and 32 patients were changed from tafamidis. We also treated post-liver transplant patients and post-domino transplant patients. This slide shows serum TTR level before and after patisiran treatment. As you can see, patisiran significantly reduced serum TTR concentration, approximately 85%. This slide shows efficacy and adverse events of patisiran. 7 patients had improvement in pain and sensory disturbance, and 5 patients had improvement in autonomic dysfunctions such as nausea, vomiting, constipation, diarrhea, and hypotension. Regarding adverse events, 8 patients had infusion reaction and 2 of them discontinued patisiran. 1 patient discontinued patisiran due to deterioration of cardiac failure. 2 patients died due to deterioration of cardiac amyloidosis. This slide shows change in cardiac amyloid deposition after patisiran therapy evaluated by amyloid imaging. As you can see, marked decrease of amyloid deposition was observed in amyloid imaging. This slide shows changes in amyloid deposition in the gastroduodenal tissue before and after patisiran administration. As you can see, patisiran significantly reduced amyloid deposition in the gastroduodenal mucosa. This slide shows serum neurofilament light chain (NFL) levels before and after switch from tafamidis to patisiran. NFL is a blood test that increased with nerve damage. As you can see, serum NFL level decreased significantly after switch from tafamidis to patisiran. As I showed, patisiran dramatically improved prognosis of hereditary ATTR amyloidosis. However, it still has problems, including high frequency of infusion reaction, every 3-week intravenous drip infusion, and long treatment time. Therefore, vutrisiran was developed to overcome these problems. In Japan, vutrisiran became available in 2022. After the approval of vutrisiran, all patients who had been receiving patisiran were switched to vutrisiran, and many patients on tafamidis were also switched to vutrisiran. In a hospital, 73 patients are being treated with vutrisiran, and vutrisiran is the most commonly used drug for hereditary ATTR amyloidosis with polyneuropathy in Japan. In addition to disease-modifying therapy, symptomatic therapy is also very important. For neuropathic pain, drugs such as mirogabalin, pregabalin, gabapentin, duloxetine, venlafaxine, methylene, tramadol, and opioids are useful. In addition, patients need to be careful not to get burned by heating equipment. For orthostatic hypotension, recommendations are as follows. They prescribe drugs that cause hypotension if possible. Increase water and salt intake if the patient doesn't have cardiac failure. Rise slowly from lying and seated positions. Elevating the head of the bed when lying by 10 to 20 degrees. Compression garments, such as high compression stockings, and exercise. Drugs such as midodrine, droxidopa, and hydrocortisone are also useful. I'd like to introduce a hot topics on symptomatic therapy for diarrhea. Diarrhea is one of the most serious autonomic dysfunction in amyloidosis patients. Recently, we showed that diarrhea in hereditary ATTR amyloidosis is associated with bile acid malabsorption in the intestinal tract, and diarrhea is improved by bile acid sequestrants. So I recommend patients with amyloidosis to try bile acid sequestrants if they have diarrhea. Finally, I'd like to introduce predictive genetic testing for hereditary ATTR amyloidosis and asymptomatic follow-up of asymptomatic mutation carriers. I used to belong to genetic counseling department and in charge of genetic counseling of neurological diseases. This slide shows genetic counseling room of a hospital. We prepare a large room for genetic counseling because many family members may visit genetic counseling. We have 3 genetic counselors in a hospital, and I usually perform genetic counseling with genetic counselors. Many at-risk family members of hereditary ATTR amyloidosis decide to take predictive genetic testing because effective treatments are available. This slide shows follow-up policy for asymptomatic mutation carriers in our hospital. We recommend asymptomatic carriers to visit genetic counseling clinic once a year. At the annual follow-up visit, we provide genetic counseling and medical checkup, including general and neurological examination, blood test, ECG, chest XP, and biopsy. If a patient is diagnosed as already developed amyloidosis, we start disease-modifying therapies. If we cannot find any findings suggestive for amyloidosis, we repeat annual follow-up. In summary, carpal tunnel syndrome, polyneuropathy, and autonomic neuropathy are common neurological complications in systemic amyloidosis. Disease-modifying therapies such as TTR gene silencers and TTR tetramer stabilizers can halt progression of neuropathy and cardiomyopathy and improve survival of ATTR amyloidosis. The effect of disease-modifying drugs on advanced organ damage is limited, making early diagnosis and treatment more important than ever. That's it. Thank you very much for your attention.